Greetings and welcome to the ultrasound of the knee. This is a modular approach on ultrasonography of a joint wherein we start showing first the anatomy and how to routinely explore the knee, and after that we go talk about pathology. And this part will combine some of the anatomy and pathology of the knee. But in particular, we're going to look at the intraarticular portion of the knee. You might be wondering why we're going to use ultrasound on the intraarticular segments of the knee. Well, try to remember that ultrasound is a great screening tool, and while you're exploring the more referenced or more requested extraarticular structures of the knee, you and I know that you'll be passing through some of the intraarticular components of this joint. Like we said before, one of the approaches to looking at a joint is looking at the regions. In the case of the knee, you've got the four regions, starting with the anterior. We could go through the medial part of the knee, then the lateral, and finally the posterior area. Let's look at probably the window to the knee, wherein the suprapatellar bursa is where changes occur that you could more or less look at the knee superficially. But what is happening to the inside part of the knee is also very important. So effusion, crystal depositions disease, infection, and maybe even loose bodies, are intraarticular lesions, but they may express themselves in the suprapatellar region. The suprapatellar region is most famous, of course, for detecting and localizing effusion. Here in a cone down view of Netter's illustration, you'll notice the fibrillar pattern on the distal quadriceps tendon inserting on the patella. And behind it, right after you cross the suprapatellar fat pad, you see fluid in the suprapatellar recess in front of the prefemoral fat pad. In grayscale imaging, on an extended field of view, just concentrating on the superior part of the knee, you'll see the bone acoustic landmark of the base of the patella, the fibrillar pattern of the distal quadriceps tendon, the triangular hyperechoic suprapatellar fat pad, and between this triangular suprapatellar fat pad and the fat pad in front of the femur, also known as the prefemoral fat pad, you see a small amount of fluid. So this is the area that usually may and should give you some physiologic fluid. But once you have localized topographically where to localize exactly where some fluid may pool, then that's where you apply your transducer. In the long axis view, again this time with a little bit of zoom effect, you see the bone acoustic landmark of the base of the patella, the fibrillar pattern of the distal quadriceps tendon, the triangular hyperechoic suprapatellar fat pad, and the more lenticulate-shaped prefemoral fat pad. In between the two, you could now detect and appreciate the marked separation between these two fat pads for what is essentially an uncomplicated intraarticular and joint fluid. When you look at suprapatellar effusion in the long axis view, again, identify your bone acoustic landmark. And once you've done so, now you begin to appreciate that you can have an extended field of view going both superiorly towards the patient's hip or inferiorly towards the patient's leg and ankle, but it is the suprapatellar recess that we'd like to concentrate on this example. In between the distal quadriceps tendon and the cortex of the femur, you'll notice that instead of just plain fluid, we now have some rind forming in an otherwise clearly anechoic fluid. Well, this rind represents chronic synovial proliferation and thickening of this lining in a patient with osteoarthrosis. And so, aside from characterizing the changes within the fluid of these patients, you also begin to appreciate the fact that you can detect synovial changes with ultrasound. Try to remember that unless you use contrast in both CT and MRI, you will not be able to see synovial proliferation. Once in a while, a case that will come across your workshop or workstation is going to be something like this, wherein now, instead of just simply having anechoic fluid behind the distal quadriceps tendon, you have something that is more intermediate echogenicity, and in this case, again, some intraluminal debris in an individual that would actually might even represent some subacute blood. We do not see the lipohemarthrosis of an acute fracture, but here you could see the hemarthrosis in this individual. And so don't forget that aside from characterizing the intraluminal portion of the distended suprapatellar bursa, also try to assess what's happening to the synovium, which usually should be imperceptible. In this case, we could see that it is indeed imperceptible, so it's more an effusion, a hemarthrosis, rather than a proliferation around the suprapatellar bursa. Don't remember now that, well, I wanted to say don't forget, but remember now that it's best to look at anything in long axis and in short axis. Recall that we always warned you that to look around the entire volume of the suprapatellar area. And here in this otherwise unremarkably distended bursa with near complete anechoic fluid, all of a sudden you have something growing out from the prefemoral area of the suprapatellar recess. A closer look will show you that there are some fimbriae or arborescence that arises from this mass. It is entirely a benign mass known as lipoma arborescens. Because of the chronicity of the effusion in this individual, there was formed this benign mass because of the chronic hypertrophy of the fat itself rather than the synovium. Often, when you look at a swollen knee and you get a history of inflammatory arthritides, not only will this intraluminal pannus jump out at you, as you could see in this long axis view, but if you care to look around, you'll also notice what used to be imperceptible synovia now shows you a moderate thickening of the synovial lining compatible with pannus and synovitis in this individual with rheumatoid arthritis, not only in long axis but also in short axis. Loose bodies, on the other hand, will appear as higher level echoes, and depending on their density and concentration, you can have a posterior acoustic shadowing in these individuals. Of course, orthogonal planes, not only in long axis and short axis, will confirm the configuration and volumetric dimensions of this loose body, but remember that ultrasound is a dynamic type of modality. And so changing the patient's position will show you that this loose body can translate over time and distance, therefore its true nature as a loose body. It is not uncommon that within a distended suprapatellar bursa you might see this innumerable punctate or at least oval-like high-level echoes with hardly any posterior acoustic shadowing. In grayscale imaging, already you have the idea that this is going to be some form of rice bodies. These are rice bodies secondary to synovial osteochondromatosis. This finding is not specific to this disease because it could be seen in rheumatoid arthritis and in tuberculosis of the joint. In the frontal radiograph of the knee, it's very difficult to appreciate any abnormality immediately. On the lateral radiograph of the knee, you will appreciate that there are two extracortical densities. The first one is this oval density in the region of the fundus of the suprapatellar recess, and the second one is, the one in the posterior recess representing a normal variant fibula. It is the one that is in front of the knee that is the abnormality. Once you've seen this, one of the differential diagnoses is going to be a loose body. Upon seeing this, therefore, the job of the imager is to see where the donor site is. And as you trawl along the knee, you'll notice that the medial femoral epicondyle is intact throughout its entire convexity. The lateral femoral epicondyle, along with the more posterior fibula for confirmation, will show you that there is a divot on its femoral condyle. Retrospectively, when you jump back to the frontal view, you'll see the same radiolucent defect on the lateral femoral condyle. This osteochondral defect now, for confirmation, might necessitate, because of its intraarticular nature, an MRI. Here in the fluid-sensitive T2 sequence with fat saturation, around the fundus of the suprapatellar recess, you'll see this osteochondral defect, but it's actually the loose body of the osteochondral defect. You notice that there are at least bilaminar nature of this loose body. Here you notice the hyaline cartilage itself, and then underneath it the subchondral plate. This is the slice selection to be exactly over this loose body in the suprapatellar recess. Let's go to another slice selection using the same fluid-sensitive sequence, and here, confirming what we saw in the radiograph, is this large divot on the lateral femoral condyle. Once you've detected this on MR, ultrasound can once you've detected this on MRI, ultrasound can play a role in this, because now you do have an acoustic window. You can approach the knee posteriorly and again confirm the same changes that you appreciate on MR. Here on the left image, you see the morphologic sequence representing the divot. And then you've already seen the fluid-sensitive sequence showing you the same defect. And on ultrasound, again, with a posterior acoustic window, you now appreciate the fact that while on MRI, you could not completely characterize the cartilage cap over this defect, on ultrasound, you begin to appreciate that the hypoechoic curvilinear cap over the subchondral defect is now trying to regenerate. Not only that, but you also see the fact that there may be a residual fissure across the hypoechoic regenerating cartilage. Again, you could always take a look at it in a single tomographic slice on ultrasound, or employ the fact that you can move around, try to see the rest of the cartilage. On the more superior image, now you begin to appreciate that the undulation of the cartilage cap says that this hyaline structure is relatively abnormal. Underneath that, the subchondral deficiency also represents some amorphic fissures, telling us that not only was there a crack across the cartilage, but that there also is some nitrogen gas in the subchondral plate. It is essential, however, to say that we do see the cartilage cap and that it is indeed trying to regenerate. So this may at least avoid an early surgical intervention. MRI is the modality of choice to look at the menisci. However, like we warned you, when you're looking at the knee with ultrasound, you can use it as a screening tool. Now, remember the craniocaudal orientation of the transducer across the femur and tibia cuts across the intraarticular line. The joint line is where you'll see this hyperechoic homogeneous triangle, in this case of the medial meniscus. Note that it has a base of a triangle and the apex of a triangle. The base of the triangle represents the external portion of the meniscus, while the apex is the free edge. So now you can appreciate the fact that yes, we can visualize the menisci with ultrasound on grayscale, and exactly what Netter showed it in his illustration. Remember that the definition in a short axis view of the meniscus was a homogeneous triangle. Here you see that there are hypoechoic fissures cutting right across the entire swath of the meniscus in this case. Therefore, you could see clearly that what was intrasubstance hypoechoic defect surfaces on the femoral level, clearly suggesting that this is a meniscal tear or at least marked intrasubstance degenerative changes of this structure. It's not uncommon though, if you had too many triangles, that's too many menisci, then you know that this is a fragmented tear. But like we told you, it is always with MRI that we're going to confirm what's going on. But every hyperechoic fragment that you see on the ultrasound image on your left is represented by the same fragments of the MRI coronal T2 image on your right-hand side. Depending on the slice that you choose is where you might or might not see a meniscal tear. Here, a case from Dr. Tony Wong from Canada, you'll notice that anteriorly the meniscus is relatively intact. But as we go a little bit more posteriorly, you begin to appreciate the loss of the hyperechoic triangle that you're expecting to see in a meniscus. Now, of course, just turn your transducer around, and from the short axis views, now on your right-hand side, you see the long axis view of a meniscus. You begin to appreciate that the anterior portion is relatively intact, as seen by this red line, and that when I go to the posterior portion with a yellow line, you got to see what we saw earlier on the short axis view, which is the lower left-hand image. For confirmation, here you can appreciate that the triangle of the meniscus on this fluid-sensitive sequence coronal MR image shows you that there is fluid going into the tear, both on coronal and on sagittal. Again, one more time, that the black triangle of the fibrocartilage of the meniscus is interrupted by this hyperechoic line. It is with ultrasound that this lesion probably is better diagnosed than with MR. That is because this case from Dr. Minh Vu from Ontario, Canada, shows us that like an ice cream cone, you have a hypoechoic collection of fluid over, representing the scoop of the ice cream, over the triangle of the sweet cone. And notice that with dynamic imaging, we're able to create and confirm that there is indeed a tear of this meniscus, creating this cyst opposing and above it. So remember that the advantage of ultrasound is being able to use stress maneuvers. Here, applying varus stress, we can shear and help create and accentuate the tear of the meniscal defect. Here you could see a varus stress applied by one of our fellows, Dr. Sung-Moon Lee, using his elbow as control. Note where his transducer is for valgus stress, and here now you could create a stress maneuver without the aid of an assistant. Another defect that could be probably appreciated better on ultrasound than MR is meniscocapsular separation, because the fluid over this area can mask out any changes of the meniscus. But with ultrasound, you could see that instead of an ice cream cone, you have a whole pancake across the entire posteromedial part of the knee, where you see this fluid collection coming from all the way from the femur to the tibia. So for meniscocapsular separation, it is a larger amount of fluid, often associated with a tear not only of the capsule from the meniscus, but also to the intersubstance portion of the knee. On this fluid-sensitive coronal image, cone down, you'll notice that the block triangle of the meniscus shows a complete tear across the medial meniscus. And sometimes you may need to employ different type of orientations in order to accentuate the pancake appearance of the meniscal cyst. And again, for the more generally accepted sagittal oblique view, you begin to appreciate the interruption of the signal abnormality across the posterior meniscus. Let's finish by looking at the extraarticular knee by cruising through the rhomboid fossa. In the posterior knee, there'll be several lesions that you'll be looking for. This would be the Baker's cyst, aneurysms, venous thrombosis, hematomas, and posterior cruciate ligament tears. Of course, in this region, you may have some masses as ganglion cyst. The rhomboid fossa, as you can see, contains the neurovascular bundles, but also the posterior portion of the knee joint. The normal bursa on the medial aspect of the knee is the semimembranosus gastrocnemius bursa. So with the transducer across the medial aspect of the knee, try to identify on ultrasound 3 landmarks. The 3 landmarks are going to be the hyperechoic convexity of the posterior condyle of the femur. The second one is going to be the bristle pattern of a short axis view of the semimembranosus. And then slightly laterally, you'll see the styronite appearance of a transverse or short axis view of the medial head of the gastrocnemius. In between this triad exists the normal semimembranosus gastrocnemius bursa on short axis. On long axis, most of us would like to park ourselves between the pannate structure of the medial head of the gastrocnemius and the fibrillar pattern of the semimembranosus in long axis as it inserts on the posterior tibial condyle. Here you see also another landmark, which is the posterior femoral condyle, and in between the 2 bones of the femur and tibia is the hyperechoic triangle of the posterior horn of the meniscus. A Baker's cyst, when seen in the long axis view, could exist with one limb in between the gastrocnemius and semimembranosus, or sometimes all the way posterior to the medial head of the gastrocnemius. Here you see a schematic drawing of the position of the Baker's cyst, and it's always a medial structure or lesion. And again, when the semimembranosus gastrocnemius bursa becomes extended, it is indeed now known as a eponymic Baker's cyst or a popliteal cyst. So therefore, the Baker's cyst can only exist on the medial aspect. Now, when it distends, it has this horseshoe pattern or boomerang shape, as you can see on MR, and a reverse image of the Baker's cyst as we try to mimic the position of the MRI. Here again, between the triad of the cortex of the femur, the tendon of the semimembranosus, and the muscle of the gastrocnemius, you got this horseshoe lesion of a Baker's cyst. So in short axis, therefore, what is supposed to be a small non-distended bursa can balloon out to the eponymic Baker's cyst on the medial aspect of the knee, and in the long axis, coming from a short axis view, note that it is now in front of the gastrocnemius and behind the semimembranosus. But it's the contour of the cul-de-sac of the Baker's cyst that's important, because note that it's got a rounded contour or shape to it. The minute the round cul-de-sac turns into an amorphic type of fluid collection or elongates, then you have a leaking or ruptured Baker's cyst. Sometimes it ruptures all the way down to the ankle, as in this case in a patient with rheumatoid arthritis. You've got pannus collecting well within this Baker's cyst for a dissecting type of lesion in this patient. We're going to finish the intraarticular, we're going to finish the intraarticular knee by talking about the posterior cruciate ligament. On the downsloping part of the posterior tibia, the name is known as the intercondylar area, you'll notice the fibrillar or partly anisotropic fibrillar pattern of the posterior cruciate ligament. Any change in the contour, size, and echogenicity of the posterior cruciate ligament should raise the suspicion for a tear. Case in point, in the same individual showing the contralateral knee, you'll notice that the contour has changed from something like a triangle to a convex upward contour. Also, look at the difference in size. It has now become almost twice the size of what the normal asymptomatic posterior cruciate ligament was. For confirmation, it is always helpful to look for MRI. Here, instead of having a black tendon or ligament representing, instead of a black ligament representing the posterior cruciate ligament, you see that it's got increased intersubstance signal abnormalities. On a fluid-sensitive sequence, you could see, comparing it to intact anterior cruciate ligament, that the interruption of the posterior cruciate ligament shows this increased signal abnormality representing the hematoma. I'm going to skip this and go to conclusion. Okay? So finally, for the ultrasonography of the knee, remember that you are going to be crossing some of the intraarticular structures. And when you do so, then most of this will be because of abnormal fluid, especially collection of fluid in the suprapatellar recess. And the most obvious indication and the most common indication you'll be using this is to confirm the presence of a Baker's cyst, which can only exist on the medial portion of the knee. Last but not least, although we will still continue to use MRI for meniscal lesions, it is so much easier. It is easier to detect meniscal cyst and meniscal capsular.
I can hear that.
Ooh. Last but not least.
I'm going to start from the one previous.
Okay.
Like right there. Okay.
It is the most common indication to examine the knee. The most common indication that is requested to examine the knee is because of a Baker's cyst. Remember that it can only exist on the medial posterior portion of the knee. Also remember that MR is what we're going to be using for the knee. But let me conclude by telling you that it is so much easier to visualize a meniscal cyst or meniscocapsular separation with ultrasound because of its more or less extra-articular position in the knee. Thank you so much for your attention.